So welcome. It's a couple of minutes after. Why don't we go ahead and get started? My name is Ronnie Shure. I volunteer as president of our board of directors for Healthcare for All Washington. Tonight we'll discuss take a deep dive into two parts of our legislative agenda, the top priorities, the top tier issues in our state uh, legislative agenda. And also in our second part, we'll be in talking about our national agenda. Thanks for joining us. You too can volunteer with Healthcare for All Washington. We've already gotten volunteers this week, so thank you for stepping up. We have a policy committee, a communications committee, a fundraising committee, an outreach committee, and as well, you can help with just one specific project or two specific projects where you can offer us advice. In this Zoom meeting tonight, there will be a chat, which where we will post a link to our website where you can find a donate button, which would be great to donate. You can also navigate to the Get Involved button to volunteer. And and if you're volunteering or checking out that website information, please feel free to make a donation. We've set a goal tonight to raise $250, and you can go to the chat anytime during the presentation to find that link to make a donation or to get involved, to volunteer. The website does have our advocacy goals, so you can follow along with that. And we will download tonight's information, the PowerPoints that we're going to present tonight. In the chat, we ask that you add questions there. We will track the chat in order to bring up those questions, and we'll have Q&A sessions like in between, at the completion of each of the presentations, so we can address state issues and then step in and address the national issues. So enter your questions in the chat. And there also, we'll notice that when you hover at the bottom of your screen, there is a closed caption icon at the bottom of the Zoom screen, and you can notice or you can see the uh, that icon, and that'll bring up some of the uh, programs for tonight or the programs for tonight. Uh, so I wanted to share this uh, as a set of a land acknowledgement tonight. I wanted to go through a quotation, not a poem, but a poet, Joy Harjo, who was a Native American poet laureate for the United States. She was not asked to speak at Trump's inaugural. Surprise that he didn't ask a Native American poet laureate to do that. And he didn't do that in 2017 either. But she wrote this statement for those who govern, and she asked seven questions. And I thought I'd run through those seven questions, give you a second to think about those. And I know this is not a poem. In fact, that's what Joy Harjo, who's a member of the Muskogee Creek Nation, said. So the first question was, can you first govern yourself? When we think about our current president, we wonder. I don't think I can say strongly that's a yes. The second question Joy asked was, what is the state of your own household? And the chaos that we're seeing nationally through President Trump seems to reflect his own household, the chaos in his own household. The third question is, do you have a proven record of community service and compassionate acts? And I think we know that he has been in a business perspective rather than a community service perspective. And I don't know if compassion is a word that we would use to describe him. The fourth question, do you know the history and laws of your principalities? A good person governing even the smallest organization or group should know that. He doesn't seem to have a good idea. Do you follow sound principles? I don't hear anyone laughing yet, but does he look for fresh vision to lift all the inhabitants of the land, including animals, plants, elements, and all who share the earth? I don't think I can say yes to that. The sixth question, are you owned by lawyers, bankers, insurance agents, lobbyists, other politicians, or anyone who would unfairly profit by your decisions? Profiting by some of Trump's decisions has been a hallmark of his work. And finally, do you have the authority by the original keepers of the lands, those who obey natural law and are in the service of the lands on which you stand? I think we can say no to almost all of those questions. So thanks for taking a moment as we appreciate the value that Native Americans bring to our lives, to our perspective of the world. So let me bring up our speakers for tonight. And if each of you could unmute, uh, and because my mouth is not working that well, I'm going to bring everyone up and then we're going to give them a chance to introduce themselves.
Well, good evening. My name is Roger Gantz. I am a member of Healthcare for All Washington, a member of the Policy Committee, and on behalf of Healthcare for All Washington, I'm also serving on the Universal Healthcare Commission's Finance Technical Advisory Committee in its efforts to support the work of the commission.
And good evening, I'm Lonnie Johns-Brown, and I have the great pleasure of being the lobbyist for Healthcare for All Washington. And I've been a lobbyist in Olympia for 41 sessions, working on healthcare almost every single session, actually, I'm happy to say.
Before we begin our presentation, have the presentation, and you see before you the agenda for this evening, I'd like to, if I might share with you a couple thoughts and comments. One is, I think, as most of the participants in this evening's meeting know, that Healthcare for All Washington has been the leading advocacy group to implement Senate Bill 5399, which established Washington's Universal Healthcare Commission. And as you may know, the commission was directed to design and prepare a healthcare system that provides coverage for all Washington's residents through what they define as a unified financing system. A second charge of the commission's work was to make available and increase access to healthcare for Washington's residents. So they were kind of commissioned with what I would define as a twofold strategy. And to that end, our policy committee's work has been also on a twofold pathway. One of those has been to seek to strengthen and support the work of the commission itself. And we'll be talking about some of those efforts this evening, including increasing the financing resources that are available to the commission, participation on the FTAC work group, strengthening what I would believe is the public decision-making process for the commission, and providing key input during their public comment section on pieces of work that they're engaged in. We've also are engaged in the second strategy, which are what I would call transitional solutions. And some of the items that we'll be talking about this evening are of our work that parallels the directionality that the commission itself has identified for its transitional work. So the first of those, Ronnie, if you could go back to the other slide, please. Good. Just
Uh,
yeah.
Okay,
So first item is Lonnie.
great. Thank you, Roger. So to kind of ground us in what is going on in Olympia this year, I bet there isn't anybody on the Zoom this evening that's not aware that we have just within our own state budget a very serious shortage. We're looking at 12 to 15 billion dollars short in the next 4 years, and the main focus of the new governor right now is to have his agencies go through a 6% cut exercise. I'll give you one example of what that could look like just at 6%. Out of the Department of Social and Health Services long-term care program, that would be a $1.3 billion cut. So, yeah, I heard somebody go, have an exclamation there. So this is serious stuff, and everything that we're doing kind of is within that context, because that's the legislature's #1 priority. We have a new governor, we have 20 new House members, we have a bunch of new senators, new heads of agencies, and all these folks are trying to learn their jobs and fix this problem at the same time. So obviously, if you're interested in helping us support revenue, we'd love to talk about that at some other point. But that budget hole is impacting all the policies that all of us care about. So Roger, I'll let you start there.
Okay.
Policies.
Ronnie, can we go to the next slide? Yeah. So a little bit of background, as I think I mentioned to you before, for this previous biennium, the one that we're in today, through our advocacy work, we were able to increase funding for the Universal Healthcare Commission by over 60%. It was close to $1 million or $500,000 of additional resources for the commission. What you see here now is what is before or what's reflected in the governor's budget that was submitted for this coming biennium. Now, this is what would be Governor Inslee's budget was approximately $723,000 and 1 FTE for this coming biennium. I beg your pardon, I got the wrong numbers there. Excuse me, it was $514,000 for this coming biennium. What we are going to be strategically working on, and Lonnie will be talking about here, are strategies to sustain the work of the commission, both financially and to that degree, maybe its existence itself. So, Lonnie, could you talk a bit about some of
Yes.
that effort?
Thank you. So before the true magnitude of our problem became clear, and this is without any change at the federal level, which you all know is pure chaos. Senator Cleveland very nicely put forward to the Ways and Means Chair a request for the $514,000 that would bring us up to the 2 FTEs and enough money for consultants that we had won in the last budget. And that, of course, is before that committee. In my experience and what we're hearing from the new governor's office is one of the low-hanging fruit when you have to start shrinking your budget is things like boards and commissions. So in that light, we've been thinking about when push comes to shove, what else could we ask for? So we've got a couple of, we could go with the base budget, which is the current $514,000. If they don't want to eliminate entirely, we could ask them to stay our funding or cut it even more. But our ultimate goal, including maybe moving to another agency, is to keep that commission in place. Because once they revoke that statute, then we don't have a platform for this work. So we're not to that the worst case scenario yet, but we have to be thinking ahead about that. And we've been working with legislators about thinking through what we could do if needed.
Okay. Ronnie, could you do the next slide, please? So what we're going to be focusing on now, these next 3 slides are work that the Healthcare for All Washington did last session to create a series of proviso studies to try to build and go forward with efforts to, again, strengthen our state's healthcare system. And one of those, what we're calling the Medicaid Health Benefit Exchange Bridge, was a proviso study that asked the Washington Health Benefit Exchange to analyze the development of an automated enrollment system for persons who are leaving or losing their Medicaid coverage and could otherwise be enrolled in a plan, many times a zero premium plan, in the Health Benefit Exchange. Some of the work out of that proviso study that the exchange did was some data that suggests that if you look at the number of folks who lose Medicaid coverage, who do not otherwise come back onto Medicaid, only about 20% of the people end up obtaining coverage through the benefit exchange. Now, several other states which we'll talk about here have begun the process of developing what is referred to as an automated enrollment system. So based on the Health Benefit Exchange review of automated systems that Massachusetts, Maryland, California, and Rhode Island have designed, and you see the implementations there, the Health Benefit Exchange recommended in their report an automated system based upon the model that California has successfully implemented. The proviso report identifies that to implement such a system, would take approximately $4 million, and they're estimating approximately 2 years to implement that. One of the positive aspects of that report is that they, being the Health Benefit Exchange, indicated that the financing of the auto-ordered enrollment system could be through their technical support account. And what that means is that this expansion would not require what we refer to as state general funds, which is the primary source for funding, health services, social services, and the biggest book of business in the state. So there's alternative funding sources in theory, but I think Lonnie will point out, and she says wisely, all money is green, and certainly the legislature and its needs could look elsewhere. That said, our policy committee has begun to work with key legislators to develop a budget proviso that would direct the exchange to begin implementation of this auto enrollment system. So, Lonnie, can you kind of give us an update on what?
Sure. The proviso has been written, and Senator Riccelli was on the requested that. He was the sponsor of the proviso study, and Senator Robinson and Senator Macri are reviewing that now. At this point, it is something they would all like to do. By April, we'll see where we are, but the good news is this is something, particularly given the Health Benefit Exchange's generous offer to use their own funds, is something that is well in the realm of the possible right now.
Yeah. And if I might stress, and my colleagues in the policy committee have heard me say this before, is I think this is an incredibly important effort, and will result in a material increase in persons who otherwise lose their Medicaid coverage coming onto the exchange. I think this is a strong policy that supports our Healthcare for All Washington's efforts to ensure that all folks have access and availability of affordable healthcare coverage. And this should we be successful as proviso, would really strengthen that effort. Ronnie, the next one. By the way, as we're going through these studies, we have set up at the end of this period for questions and hopefully answers from us. So stay tuned as they may come forward. Another one of our proviso studies that we worked with the legislature on was a study directed by the Healthcare Authority to analyze and report on the consolidation of the Public Employees Benefit Board, the School District's Benefit Board, and a key aspect that of combining the SEB-PEB purchasing pools into a single pool. I might add to this is this concept of a single pool. It does not include retirees who are over 65 years of age and otherwise eligible for Medicare. So retirees, as has always been the case under this combined one, would still be in a separate purchasing pool. And again, primarily their coverage is through the Medicare program. There has been legislation introduced, House Bill 1333 and Senate Bill 5086, that would consolidate the SEB and PEB boards into a single 13-member board titled the Washington Employee Retiree Benefit Board, and would consolidate the SEB and PEB purchasing pools into a single pool. As I say again, the pool would not include retirees over age 65. The other aspect that was in our proviso study request that didn't find its way into the final one was to look at ways to improve how the Healthcare Authority purchases healthcare through this concept of competitive consolidated contract or selective contracting, excuse me. That was not part of the study. However, through the Healthcare Authority has requested legislation through House Bill 1123 and Senate Bill 5083 that would allow and direct the Healthcare Authority to implement what's referred to as reference-based pricing for PEB and SEB healthcare purchasing. And you see a note above that is this notion of reference-based pricing was one that's been already implemented by our sister state, Oregon. They did so in 2019, and based on some audit findings from the first 2 years of that reference-based pricing, they've seen nearly $172 million in savings in inpatient and outpatient hospital services. So reference-based pricing really works. The bill that's being proposed essentially would do two things. One, it would set a price cap for hospital services, inpatient, outpatient hospitals at 200% of Medicare equivalent amounts. So it's at 200% of Medicare. And it does something innovative. It creates a floor, and that is that for carriers in the health benefit exchange market and through UMP, would have to have payment rates that are at least 150% of Medicare for primary care and behavioral health services. So one of the things, again, 1123 and 5083 does is attempt to redistribute, if you will, some of our healthcare dollars from hospital services to critically needed primary care and behavioral health services. One other note, if I might, is that the fiscal note for this bill would indicate that savings for the current biennium coming forward, that is the 2025-27, would be something in the order of about $71 million because it takes a year to get it implemented. And for the next biennium, 27-29, is forecasted to yield about $350 million in savings. So, Lonnie, again, could you kind of give us what status on those family of bills are?
Yes, I don't think this should come as a surprise given the fiscal savings that Roger just shared. But 1123, the House bill, is already in House rules, and Senate Bill 5083, the companion, just got voted out of Senate Healthcare and is now in Senate Ways and Means. And I'll just take a second here to let people know that policy bills that are purely policy need to be out of their original House Policy Committee by the end of the day on Friday, February 21st. And then if they get referred to the fiscal committees, they need to be out of those committees by the end of the day on Friday, the 28th. So it's a good thing that bills like this are moving. Thanks, Roger.
Mhm. Ronnie, can we go to the next one slide, please? Okay, the last bill we're going to be talking about, this presentation is simply titled Corporate Practice of Medicine. It's House Bill 1675 and Senate Bill 5387. And it does two conceptual things. One, as you can see from the slide, it prohibits corporate practice of medicine except through a professional service corporation or limited liability company. And secondly, it prohibits individuals not licensed as medical to practice medicine from interfering with clinical decisions made by licensed facilities. That's hospitals, ambulatory care centers, etc. So it places some restrictions in terms of how medicine would be practiced in our state. And you can see the other two things here. Says that some of the requirements of professional service organizations in terms of their membership, the majority of directors and corporate officials, and likewise restrictions on the practice of medicine. Lonnie, could you?
Yeah, I'd like to just add a little bit to that. This is really about the growing practice of investment groups who are not doctors and don't want to practice medicine buying up hospitals, doctor groups, that sort of thing. And their pure motivation is profit. And so this legislation came about to try to put some rails on that to prevent more of that happening and make sure that folks that are running these kinds of groups actually are folks from the medical with medical backgrounds. So the House bill has not seen much action. This bill was dropped pretty late in session, but the Senate Healthcare Committee heard it on the 7th of February. No action, executive action has been taken or scheduled yet, but they add and change those agendas as we get closer to that deadline all the time. And then I'll put one more wonky piece of information in front of you. We call them biennial sessions because they're really considered 2-year sessions. So every bill introduced this year that doesn't pass will be alive and before the legislature again next year. And some bills like this one may need a little more time and work in the interim, but it is a huge step, I think. Thank you.
Lonnie, could I add one other point? I know this discussion that many of us had on horizontal and vertical integration. There is a report issued under legislative direction by the Office of the Insurance Commissioner. They issued 2 reports, year 1 and year 2 report. The second year report probably got more plague because it identified 5 options for cost containment through their contract with HMA. They did a detailed actuarial analysis of each of those options and have presented that report to the legislature. But the year prior, again, they did a report with the Office of the Attorney General that looked at horizontal and vertical integration experience over the last 10, 15 years in our own state. So in that report, you can find some good information about the consolidation that's been occurring in our state in terms of hospitals, which we've seen a great deal of, as well as what we call vertical integration, that is the consolidation by hospitals or other entities of physician practices, et cetera. So it's a good background report and information on this topic. And I think the last one would be from us is our possible questions folks might have.
Time, Ronnie. We need to move on.
We need to
So
move
let's
on.
look in the chat. Uh, and question is for those without health insurance. No, that's not a question, is it? Uh, would that include uh, big national medical groups such as Optimum? Uh, and I guess Dr. Sobek is really addressing the corporate practice of medicine bill.
Yep, that was for me.
So the bill we just talked, would it cover Optimum?
Yeah, I mean, there are private equity companies that don't necessarily have physicians running them, but Optum as a national company is largely physician owned or physician based. So, they're a national company that drives, healthcare decision making and healthcare reimbursement in the state. So would that affect them?
Uh, I'm seeing Lonnie shake her head no.
No, not as it's written, but again, I'm kind of jumping out here and predicting that this bill probably isn't going to see a lot more action next year, but the opportunity for us to really get to know it and talk to the sponsors about what we think is missing or what isn't clear, is something. I see Sherry's hand up, but um, I don't think as it's written right now that it would capture Optimum.
So another question is, given the 4 million cost for auto enrollment for people who have lost Medicaid benefit, how does that stack up against the cost of emergency room services or the cost of dying due to the lack of care? Is $4 million a reasonable cost? It's a lot of money.
Well, I think the cost is if people lose Medicaid and we don't get them auto-enrolled into plans that they qualify for and that we as a state help pay for, we're going to see that cost of folks ending up in ERs and medical debt expand. And so I think it would that cost of not doing it, in my personal opinion, would far exceed $4 million.
And let's include one last question, which is to explain reference-based pricing.
Sure. Let me give an example, if I might, because it's what's in the bill itself. What the bill says is that for hospitals that contract with carriers that provide coverage to public employees and state school district employees, primarily these currently are Kaiser and Premier, but there are others, and for the Uniform Medical Plan, payments to the hospitals can be no greater than 200% of what Medicare would otherwise pay for those services to that hospital. So what it does, it caps the payment amount that could be made to hospitals. So if on average your payments are below 200% of the federal poverty level, uh, I'm sorry, 200%, not poverty level, 200% of
Medicare.
Medicare, excuse me, not Medicaid, but Medicare. Here we go, Roger. Your payments from the healthcare authority or from these carriers would not be impacted. If, however, your costs, your payments otherwise would be greater than 200% of Medicare, you payments would be capped at that 200% level. So reference pricing says we're going to look at a price that we're going to set a maximum payment about, and maybe as we have in our bill, a floor. And when you hear about reference pricing, almost all models today rely on Medicare as the reference price because it's the most broadly used price structure in our healthcare industry.
Well, thank you, Roger. Thank you, Lonnie. Let's bring up Cello, if I can find you. Are you hiding in there? And I'm going to disappear and share some more slides. Oops. Did I remove you? No. At Spotlight, I want to remove me.
You can stay.
I'm getting close here.
It's okay. Take your time. I'll have a glass of water. Should be something in there about slideshow.
That's what I thought.
Yeah, like you did with. That's okay. We can do it like that. I don't mind. So I think, um, given where we are politically, right now, I'm going to spend a little bit of time talking about three federal bills that have, I think, draw across right wing or Republican or rural communities if we pitch it correctly. And then I have at the very end of my deck some ideas about how to move us forward from readings that I've done from other organizations that I'd also like to talk about. But I'm going to start with this State-Based Universal Health Care Act. And I'm sure everybody here has heard about it, but very, very briefly, it is a super waiver that allows the states to access some federal funds for their own state-based universal health care program. Representative Rokana agreed to reintroduce it in the 2025 session with 30 co-sponsors, which very nicely is up from 20. We only had 2022 co-sponsors in 2019. But unfortunately, there has been no change in the number of Washington state representatives who want to sign on, and only our heroes, Representative Jayapal and Smith, are still on as co-sponsors. And this is kind of a call to action that we really need to figure out how to get our representatives here in Washington state more active and get them to sign on. Edward Markey, after some consideration, and especially after the Steward Health crisis, I think the disparities in healthcare became very, very clear for him, and he agreed to run a bill in the Senate with only Elizabeth Warren as the co-sponsor. And of course, there are none from Washington, D.C. Representative Jayapal is also coast. No, I'm sorry, that's the other bill. Sorry. And because we always have to acknowledge those that came before us, I do want to acknowledge that Representative Jim McDermott first introduced this same concept in 2015. So it's really important that we acknowledge that this is a long-term fight and we are in it for the long term. Next slide. So I mentioned that Sabuca, why do we need it? So we know that in Washington state, particularly, the federal government funds about 50% of of our medical needs in Medicare, Medicaid, and CHIP recipients. That's a lot of money that we cannot necessarily get our hands on because the Affordable Care Act doesn't allow states to use those funds for their own programs. And that is where this waiver. Highly nutritious food. Hello? Is there a question? No. Okay. And that is why where the super waiver really comes in, because it allows states to access these funds, and it also addresses any potential legal challenges to ERISA. Next slide, please. What exactly does it do? Well, a lot of people who are opponents of state-based plans are opposed to it because they believe with some, validity that especially states in the South will have plan, if they are allowed to do their state-based plan without federal oversight, will put into place plans that discriminate against people of color or poor people or people with mental health issues or withhold certain types of care like abortion services. And in fact, SABUCA mandates that the benefits have to be equal or greater than the federal health care programs. And this is a point that I actually am not for. It only guarantees coverage of 95% of residents, not 100% of residents. And I don't quite understand why it's 95. I think that we need to change the language about that. Um, it does allow groups of states to come together and apply jointly for a waiver. So, for example, in our Washington-Oregon collaborative, which I'm going to mention a little later, that might be potentially a topic that we talk about, how to apply jointly for a waiver. I mentioned before access to Medicare funds, and what's really for people that are hesitant to allow states to move forward, especially for those who are not advocates of Medicare for all, not advocates of state-based freedoms. It's really great. We can point out that it creates this independent assessment panel that will review and make recommendations regarding the waivers, and the panels are composed of members of both parties, both Republicans and Democrats, as well as healthcare providers and advocate groups. Next slide, please. So here in Washington State, what do we need to do? We need a bill, like whole Washington's the WIT, Senate Bill 5233, or Healthcare for All's not yet a bill, but hopefully to be a bill, the WIST, Washington Health Security Trusts. And these bills include implementation plans, coverage details, targets, and costs. We need a detailed 10-year budget. Go back. There we go. And we need proof that Washington has the capacity to run our own program. And that's where this Bill 5082, and I forgot the House companion, is really important because it allows this Washington state to prove to the feds that we have the capacity to run a large-scale healthcare program. And we really do need your help. So please give us a call. Tell your story to Murray and Cantwell and your representatives and urge them to support SABUCA in both the House and the Senate. And if your member of Congress happens to be Adam Smith or Pramila, please call them and thank them. And that's all for SABUCA. On to the next one. Oh, no, go back. Go back. Sorry. Back one slide. Can't you just go back with the little back arrow? It's not letting you go back. Okay, well, in the slide deck, there we go. So in the slide deck, I have put in, because everybody will have access to this, I have put in here in One Payer States, which is an organization, it's a clearinghouse that organizes, that is, well, it's a clearinghouse, a repository for states to get together and discuss strategy and share resources for when we move our own state-based plans forwards. And we have written these 5 pitches, one for the general public, one for supporters of improved Medicare for all, one for moderate progressives who are not quite on board with Medicare for all, one for businesses and conservatives, and then Charlie Swanson wrote a beautiful little one-pager that just lays out very clearly what is state-based universal health care. If you all are interested in speaking to other people, please be aware that these resources do exist and you can use them at your own convenience if needed. On to the next slide. Okay, so then we have the Health Over Wealth Act, and we were just talking here in Washington State how we are trying to control the privatization of healthcare nationally after the horrific Seward health crisis. Markey, along with Jayapal and Senator Warren as a co-sponsor with Markey, sponsored the Health Over Wealth Act 4804 in DC. And we all know the horror stories. I don't need to go. We all pretty much understand why we need to do this, but I would just like to read what Markey said and encourage people to please watch the video. The panel that he put together, When Healthcare Becomes Wealth Care, How Corporate Greed Puts Patient Care and Health Workers at Risk. It is an extremely powerful group of speakers, from health advocates to attorneys to doctors, who talk about the moral injury that happens when venture capitalists take over their healthcare system. Next. And finally, this bill, I don't know if a lot of people have heard about this. This is our Save Our Medicare Act. And this, during this period of open enrollment for Medicare, and we have Medicare Advantage plans that are, advertisements on Facebook, at least I see them all the time. Representative Jan, I'm going to screw up her last name, Schakowsky, is that correct? Mark Pocan, please excuse me if I say it wrong, and Ro Khanna reintroduced the Save Medicare Act. And basically what it does is it does not allow private insurers to co-opt the word Medicare when they're selling their plans, their for-profit plans and titles. For example, it would ban the use of Medicare Advantage. And this is what she said. I love this quote. "Don't be fooled. Medicare Advantage is not Medicare. I am extremely concerned about the deceptive advertisements that Medicare Advantage plans are using to trick older Americans into signing up for these plans. This is a plan that I believe can get bipartisan support because many Republicans have constituents who are older, who are unhappy with their medical with the state of their medical care and providers and the rates of denials. And I'm really hoping that this will move forward in the 2025 year in DC. And next slide. So I'm going to be very frank with everyone here. I am trying not to fall into despair. I'm trying not to feel like I'm under attack. I'm trying not to feel that, we are on the verge of fascism. And out of action comes hope. So here are some resources that we can use to give us hope. I found this amazing this amazing organization online. They're called 5 Calls to Make Your Voice Heard. They're very simple actions that you can use, everything from healthcare to roads to green energy to solar energy to protecting the environment. It's a whole range of issues, and it's a really effective little tool. We also know that healthcare can go nowhere and we cannot have any substantive change without unions. So I'd like to plug Rose's Roach campaign, labor campaign for single payer. This is an excellent organization. And in fact, we just held a summit in Washington State in August of last year, 2024, where Rose came and spoke, and we had, I believe, about 12 or 15 different organizations, over 40 people in the room discussing how we can activate labor. And out of that now, through some labor boards in Washington State, we now have single payer amendments, or what are they called? Declarations that these boards are putting out. Another great organization is One Payer States, the clearinghouse for states to come together and discuss issues and share resources. One of the unsung heroes, I think, of Washington State is Washington Healthcare is a Human Right. It's a coalition of many, many organizations, I believe over 32, from labor to women's rights groups to immigrant rights groups to lawyers to healthcare activists. It is really a gem. And another shout out to remember those that came before us. This idea was formed out of Washington's Physician for a National Healthcare Program. So we have to give respect to them. Finally, please do support Whole Washington's single payer bill, which is in the House and Senate right now in Washington State as we speak. And we've got to get it into committee. Go onto their page. We've just started putting out announcements ourselves. Keep your eyes peeled for our action alerts on that bill. And finally, I found a really beautiful article out of Wendell Potter called "What Rural Electrical Co-ops Can Teach Us About Fixing Healthcare," and it's a potential roadmap to win. And I think that that's all I have.
Well, thanks so much, Cello. Uh, and we can still add or have questions for Cello. And if we could ask Peter to step up. Uh, I don't see you, Peter.
I'm here.
You are.
And I would, if, can I just call on David Loud to talk a little bit about what's happening with the what's Passara's bill called? I'm just blanking.
Well,
David?
Oh, are you talking about Senator Hasagawa's Senate Joint Memorial 8002?
Yes, can you just give a shout out real quick about the action item that's coming out?
Yes, Senate Joint Memorial 8002 would call on the federal government, Congress, and the administration to level the playing field between traditional Medicare and Medicare Advantage by adding benefits to traditional Medicare and making traditional Medicare more affordable, capping the out of pocket, and so this is following up on the initiative of our Washington State Labor Council 2 years ago, which was the first in the nation to adopt a resolution to level the playing field. And that is something that Rose Roach, with the Labor Campaign for Single Payer, is working on getting labor bodies, unions, and state labor councils around the country to get behind that as well. It's basically a strategy of how can we save and strengthen traditional Medicare against the threat of the expansion of Medicare Advantage, so that there's a real choice, so that people, because we know that most people that go into Medicare Advantage do so because, to begin with, it's a lot less expensive. It often has a
yeah.
few.
And it's
Yeah,
and
go ahead, Andy.
this is a national program that has originated with some activists like you in our state. So thank you for
And do
bringing that
please
out.
keep, yeah, and please do, we're putting out a whole bunch of action items. Please keep your eyes open and do take action. And Peter, I'm turning it over to you and shutting up now.
Okay, you ready for me, Ronnie?
Yeah, Peter, go.
Yeah, so I'm Peter Lucas. I'm longtime board member, treasurer, and I make the fundraising pitch. I've tried to trim it down a little bit. As you can tell, you've heard tonight about some of the legislative work in the current session in which we are involved. We've been doing this work since 1994, including being advocates for the Washington Health Security Trust, mentioned by Chelo earlier, which is a bill to create a single payer system in our state. We have a professional lobbyist, Lonnie, who you also heard from earlier. And we also have a number of other people who help out, such as board members, volunteers, supporters, and a communications specialist. With our work, all these folks, we've been very fortunate to have forged strong bonds with many of the legislators who are currently active. And many of them do support our mission and work hard to bring it to fruition. But these activities are not free. They require financial support in terms of personnel, outreach efforts, and administrative support. So you can help us out by making a donation tonight. Our goal is $250, as mentioned earlier. And I've been posting quite a few links to donate in the chat, so you can click on those to make a donation. We especially encourage recurring donations, monthly donations, because those just provide consistent support throughout the year. And we really appreciate any past, present, and future support you provide. We really believe that together we can achieve cost-effective, high-quality, universal health care coverage in our state. So thank you very much.
Thanks, Peter. Thank you, Peter. And
Welcome.
I'd like to thank Roger Gantz and Lonnie Johns-Brown and Chelo Echeverria for sharing that information, getting the items across. We will share the details from these slides on our website as soon as we can put that up. I'd like to thank our background people, D.W. Clark and Rich Legoo, who have helped make tonight's event work. I'd like to thank our communications team. We have a very powerful committee that has gotten the word out to each of you. So thanks to Marcia Stedman, Sydney Jones, Ron Lovell, Connie Rock, Chelo Echeverria, and D.W. Clark. And also our policy committee that has been working on this agenda throughout the year. Roger has shared some of that work that we've been putting together. So thanks to Denny Delwo, to Sherry Weinberg, Chris Curry, Emil Chang, Hal Stockbridge, Martha Stedman again, Ron Lovell again, Chelo Echeverria again, and a new volunteer. And as I mentioned, you too can volunteer, thanks to Sarah Kate for joining in and adding her words. So thank you all very much. We look forward to seeing you next month at our second Wednesday speaker series, the second Wednesday in March, which will be the 12th. Thank you all.